Well, with us today is Dr. Ochoa, and I said that right, didn't I?
Yes.
And I'm kind of excited about this show because, number one, people don't talk about the subject enough, and they kind of shy away from it. Breast reconstruction.
Right. For breast cancer.
Yeah.
You know, sometimes when people talk about breast surgery, sort of one of the first things that people think about is cosmetic surgery.
Right.
And, you know, that's not what we do primarily. Mm-hmm. We do breast reconstruction surgery for breast cancer and all types of breast reconstruction. Mm-hmm. So, yeah, so that's what we do every day.
Well, Dr. Ochoa, how did you choose that specialty?
You know, it's a small specialty of another specialty. So mm-hmm. it's kind of unique the way that I came about it. I started doing research with plastic surgery when I was a medical student at UT Southwestern in Dallas. Ever since I was young, I believed that I wanted to be a surgeon of some kind. I didn't know what kind. So during, I believe it was between first and second year, or maybe between second and third year, Southwestern, we still have a summer break, and they strongly encourage all the students to find a research project to be involved with. So I was kind of a procrastinator back then, so I didn't really take initiative in finding a project real early, and right before the deadline, there was a project or a research specialty that wanted people to go into the operating room to collect samples of lipoaspirates, basically what they removed mm-hmm. during liposuction, and do studies on it because they were testing out a new kind of liposuction. And I thought, oh, that sounds kind of interesting, but mm-hmm. the biggest attractive thing was to get into the operating room, and which is what I wanted to do. So I got into that program, I got into that project, and it was with plastic surgery. And the people there were very nice. All my attending doctors and residents that were working there were very nice. And they said, you know what? You don't have to just come in for the liposuction part. You can come in and watch whatever we do whenever you have a few extra minutes of the day. So I did. And I was just, you know, I think just like a lot of people, I just had this preconceived belief of what plastic surgery was. Mm-hmm. And then once I was actually doing it, I realized it wasn't what I thought it was. It's primarily reconstruction, and a very small portion is cosmetic surgery. Mm-hmm. So I got to see from anywhere from hand reconstruction to facial reconstruction from, you know, car accidents and things like that, and major reconstructions mm-hmm. that take 10 hours, 12 hours, sometimes even longer. And I was just fascinated. I thought it was, man, this is like the most difficult thing I could possibly think of to do as a career. And I thought that's my personality is, you know, let's just, you know, if you're going to go, you know, do it big, you know. Yeah. So that really piqued my interest, and I decided I'm going to be a plastic surgeon. I'm going to be a reconstructive surgeon.
So on like a pragmatic level, how are you able to stand there that long and focus? And
it takes time.
Is amazing.
You know, it takes time. It takes a lot of practice. Mm-hmm. It's definitely very challenging physically. And primarily mentally, mm-hmm. the need to focus for a very, very long time can take a lot out of you mentally. Mm-hmm. At the end of the day, if it's a tough case, you know, it's like, man, your mind is like mush. Mm-hmm. You know, there's been times, and I've told my wife this, that we've had a case or that things haven't gone as smoothly as we would like them to, and I get in my car at the end of the day in the parking lot, and I'm thinking, wait a minute, how do I get home again?
Basic things go.
You know, it's like my mind is completely and totally spent.
Yeah.
But thankfully, those are very rare occurrences. Things relatively go very smoothly.
Yeah.
So it just takes a lot of practice.
Well, if you're just joining the show, we're talking to Dr. Ochoa. He's with PRMA, which stands for
Plastics, Reconstructive, and Microsurgical Associates.
And you have two offices in San Antonio, one off Huebner, the other off Madison Oaks. People can call 210-692-1181. So the main thing that you do is for the reconstructive surgery for breast tissue. There's there's lots of different presentations that you get post-treatment.
Right.
So
right. And we like to be involved at all stages. The most common presentation is someone that comes in who's just been recently diagnosed, and has spoken to a breast surgeon, and they've gone through the options of how to remove the cancer. And now they're thinking about reconstruction if mastectomy is recommended. So then that's when we get involved, and we try to do it before the mastectomy is done. We try to do that reconstruction or that consultation before the mastectomy.
So you have a plan going into it.
Right, exactly. So if at all possible, we want to do immediate reconstruction, which is at the time of mastectomy. So the breast surgeon and I get together, we coordinate a surgery date.
Why is that the best time?
Because it's one anesthetic. It's a long surgery, but it's one anesthetic, and for multiple reasons. Number one, cosmetically, it is much better to do it in the immediate setting. So the way I talk to my patients is think of your breast as a pillow in a pillowcase. So the breast tissue, which is the pillow, that's the part that gets cancer. The pillowcase is the breast skin. The breast skin can be left behind completely when a mastectomy is done and reconstruction is done in the immediate setting. So you remove the pillow, you leave the pillowcase behind. You leave the pillowcase behind, and then I get to fill up that pillowcase with something different, with a new pillow, whether it's an implant or whether it's patient's own tissue. I get to fill up that pillow with something different.
Emotionally, that would be
that's another
and psychologically, just a better route to go for the patient too.
Right, exactly. So from a cosmetic standpoint, it's ideal. From a psychological standpoint, it's ideal. So there's many benefits of doing reconstruction in the immediate setting.
So what if the patient is requiring radiation? Does that affect what you do?
Absolutely. So if a patient presents with a cancer that is advanced, whether it's a large cancer in the breast, or what I mean by advanced also is if there are multiple lymph nodes that we know that are also positive for cancer. Those cancers spread from the breast over to the lymph nodes. The most current recommendations is that if they're a certain size within the breast, anything over 5 centimeter diameter breast cancer in the breast, they need post-mastectomy radiation. So even after the mastectomy, radiation is required. Same thing for the lymph nodes in the axilla. Anything over 4 lymph nodes in the axilla.
Because they're scared it's going to
Right. So in those patients, whether it's a large cancer in the breast or multiple axillary lymph nodes that are positive, those patients have a higher incidence of recurrence of cancer. So in order to decrease the possibility of that, radiation is recommended to the chest and to the axillary area. So if I see a patient that has been diagnosed with a cancer, and by MRI, ultrasound, whatever imaging that they've had, it is determined that they have multiple lymph nodes that are positive and the cancer looks to be fairly large, those patients, we already know they're going to need radiation even after mastectomy. Most of the time, I have to tell those patients, I can't do reconstruction in the immediate setting. I have to wait until the radiation is completed. So mastectomy is done, no reconstruction. After the radiation is completed and the skin heals, we go back to surgery and do a reconstruction from the very beginning. Now, in those situations, the reconstruction options are more limited because of the radiation. So that skin has now been radiated. It is much tougher. The elasticity of the skin is affected by the radiation. It's very difficult to stretch. The body just doesn't like radiation. The radiation can have very long-term effects. So one of the main reconstructive options, which are implants, are not going to work in that setting. They may look okay for the first couple of months, but invariably there's going to be problems with that reconstruction.
Is it with infection, or what is it?
Infection is like
necrosis of the skin, or
it's infection. Primarily, the most important or the most common complication is something called capsular contracture, What that is basically the body forms a shell around an implant. The body forms a shell around anything that's not yours, whether it's a prosthetic knee, a hip, blah, blah, blah. It forms a shell around that. It tries to wall it off from the surrounding tissue. So the body forms a shell around an implant, whether it's a cosmetic implant or a reconstruction implant. It forms a shell around it. With radiation, that shell becomes very, very thick. And that thick shell not only affects the how soft the new breast feels, but it also can displace the implant to positions that are not ideal, and sometimes can be very very painful also. So usually with radiation, we have to use something besides an implant.
I see. Well, we're going to take a quick break, and then when we get back, I want to talk about the type of materials that you are using for that specific set of patients. And then also, obviously, it's not just females that are getting this
breast
type.
Cancer?
Yeah.
Right. There's a small number of males that get breast cancer, and oftentimes those are there's a high incidence of those having some sort of genetic
component to it. Well, let's talk about that when we come back.
Okay.
Be right back.
What the flower people say. Listen.
Do your loved ones say you're not listening? Do they tell you the TV's too loud? Or do you have ringing in your ears or feel dizzy without explanation? Call Associates of Audiology. They are the experts at diagnosing and treating hearing loss and balance disorders for all ages. Call 210-334-0245 or see them at associatesofaudiology.com for a better quality of life. Don't let your ears keep you from hearing.
And we're back. You're listening to Ask the Experts of South Texas with Dr. Davis.
And Dr. Bledsoe.
And we have with us today Dr. Ochoa with PRMA plastic surgery. You can go to https://enhance.com. Or you can call them at 210-692-1181. So what we were talking about before that quick break was radiation. For patients that have breast cancer, they undergo radiation because maybe the cell was too large and they had to go in and radiate it before doing the surgery.
Right.
And then the options for reconstructive implants at that point is a little bit different approach than the standard. So what are you doing? What are you putting in there? Is it their own body tissue or fat?
Right. If they've had radiation and the implant reconstruction is not an option, or less than ideal option, then we have to use the patient's own tissue. And there are multiple sources, so you have to rob Peter to pay Paul, right? You got to.
I like that. I like that saying. You got to rob Peter to pay Paul.
Right. So you got to take it from somewhere.
Right.
And you have to figure out where can I take it from, where the source of the tissue is less affected than the least affected that possibly can. So the majority of the time we use the patient's own tissue from the abdomen, so the lower tummy tissue, usually the tissue that's sort of below the belly button area. That is the most common way to do it, and that's and that has multiple benefits of using that tissue.
Like a skin flap is what you're saying.
Skin and fatty tissue.
Okay.
So we take the skin, fat, and blood vessels because that tissue needs its own blood supply, needs its own oxygen. So we have to find the blood vessels that are bringing blood flow to that area. It's a long, tedious surgery because we have to find the very small blood vessels. The diameter of the blood vessels that we typically use for it is around 1 to 2 millimeters in diameter. So very small blood vessels, we have to find them with a microscope, dissect them out, find where they're coming from, disconnect them from the body. So it's an auto transplantation. We bring it from the tummy, disconnect it, bring it up to the chest, reconnect the blood vessels.
So it's not like a lift. It's actually removal and then resection.
Yeah, we resect it. We tie the blood vessels together by hand.
Oh, my goodness.
And then you have a new breast. So the reason why we use the tummy is for multiple reasons. Number one, that's probably the area of the body where we can take the most tissue from with the ability to still close that incision. Other reasons is that the consistency of the lower tummy fat is pretty similar to the breast. So the new reconstructed breast with tummy tissue feels as normal as it possibly could. The blood vessels, even though they're very small, they're manageable in size. And the secondary benefit is that we improve the overall contour of the lower tummy. So that's a secondary benefit of using that type of tissue. The other alternatives, what other pieces of tissue can we use? We can use the inner thigh, the outer thigh, the buttock area, and the back.
How would you use the back?
The back is sort of a different technique where we have to actually remove, move one of the back muscles. So we take skin, a little bit of fatty tissue, and a lot of the muscle. We basically swing it on a pendulum. That muscle is called the latissimus muscle. It's in the back. It's sort of starts from the spine, and sort of it's like a fan shaped, and it goes and it inserts into the humerus. It allows us to do pull-ups. That's the muscle that helps us do pull-ups. So that muscle is what we removed, or what we move. Leave it attached to the humerus, and swing it on a pendulum, and bring it from the back over to the front. We have to tunnel it through the axilla and reconstruct the breast using that. However, the problem using that technique is that the amount of volume that we're able to get is not a lot. So the muscle it doesn't carry a huge amount of volume. So oftentimes when we use that technique, which is primarily used for women who have had radiation, and for some reason we cannot use the tummy. They've had a previous tummy tuck. They've had multiple abdominal surgeries where we can't use the blood flow or the blood vessels, and we have to use that to try to offset the radiation damage that has occurred.
Goodness, that's very complicated. Well, I'm glad we have you to do it, Dr. Ochoa. So for the ones that don't get radiation, it's more run-of-the-mill. If there is, if you can say run-of-the-mill.
All the options are on the table in those situations. All the options.
So which type, so you hear a lot of different opinions on the type of implants that are being used in the recommended volume, whatnot. So what is this now the safe material that can be used?
You know, there was a big scare. I guess it was in the early 90s about silicone gel, and I think it was worth sort of pausing and doing more research into silicone gel implants, and certainly the companies that made the implants had a lot of stake in that, and they contributed a lot of money to do those formal studies. And it all came out that, okay, there are some women who have these connective tissue diseases from implants, but it was no different than the general population. So there was no real statistical, and these were looking at thousands and thousands of women that had silicone gel implants for usually for cosmetic purposes. There was no statistical differences between the incidence of these these connective tissue diseases between those women and the women who in the general population. So after the FDA reviewed all those studies and they basically critiqued every single little thing about those studies, they said, okay, fine, silicone gel implants are completely safe. We can put them back on the market. So we use silicone gel implants oftentimes when we do implant reconstruction because the silicone gel implant tends to be a lot softer than a saline-filled implant. So the overall feeling and cosmetics of the reconstructed breast with an implant tends to be a little bit better with a silicone gel implant. But certainly saline is also used very frequently.
So the risk for rupture, because you do hear some cases where they do leak or rupture. How common is that?
It's pretty uncommon. I'd say in the single digits in terms of percentages, and usually that occurs later on in the life of an implant.
Which is what typically?
Rule of thumb is usually around 10 years is when we start seeing a spike in the rupture of the implants. That doesn't mean that, let's say someone has implants that, they mark it on their calendar. Oh, it's been 10 years from this day that I had my implants placed. I need to have them exchanged on that day.
Right. My warranty's up.
Right. My warranty's up on that day. So it's not like that. It's just that at 10 years, that's when we see the spike.
You start seeing that
in implant rupture.
So do people have to have them replaced? I mean, is it really like
I
a
think
10-year
so.
warranty and you have to go in and do it?
It's
Or
like
is
your
it just
car.
if you have problems?
It's like the oil change.
Just if you have problems. Well, it depends. For example, if you have a saline-filled implant that ruptures at 10 years. So what's going to happen when that implant ruptures is that the breast will slowly get smaller.
You can say deflate.
Deflate, yeah. The breast will slowly deflate, and the body absorbs that saline.
Because it's saline.
Absorbs the saline, and then there's nothing
You can tell.
You can tell. So in those situations, let's say somebody had implants and now they're 70s, 80 years old, and they notice that their breast is deflated even more than the normal deflation, and they don't have to have them removed. They can keep them, and that's fine. If a silicone gel implant ruptures, however, then recommendations are you got to have them removed.
Can you get new ones put back in?
Yeah.
Okay.
Yeah.
I
I just didn't know if the silicone.
No, usually the majority of the time is what they call an intracapsular rupture. So this capsule that I mentioned earlier, the body forms a capsule around it. It stays there. So oftentimes when silicone gel implants rupture, they don't realize it. It's completely occult. It's just nobody can. The breast doesn't deflate like a saline-filled implant. So that's one of the things. That's one of the drawbacks of having a silicone gel implant is that the screening or the detection of a rupture is a lot harder.
Well, we're going to take a quick 30-minute break at the half hour. Well, it's half-hour break. We're 30 minutes in. But when we come back, I want to talk about when to get tested for prevention, what types of testing they need to have done, and kind of the benchmarks for that.
Okay.
And then if they see something, who do they call? What do they do? What does that process look like? And we'll be right back in just a minute. We are back here listening to Ask the Experts of South Texas. I'm Dr. Davis. The person that was just coughing is Dr. Bledsoe. Sorry. And we're with Dr. Ochoa from PRMA Plastic Surgery. You can go to PRMA-enhance.com or you can give them a call at 210-692-1181. So now the process of being referred to you as a patient really is going to be interdisciplinary, where you've got the other three doctors working with you, and it's more of a team approach. So you got the oncologist.
That's the chemotherapy doctor, right?
Right. You've got the radiation doctor.
Mm-hmm. Right.
There's also an oncologist.
He's what they call a radiation oncologist.
Okay.
Right?
Mm-hmm. So who are the other two? You, of
Me,
course.
the reconstructive guy,
I'm
and
missing
then
one.
there's the breast surgeon. So all four of us sort of have input into how to treat the patient.
Mm-hmm.
Oftentimes it's pretty straightforward, and sometimes it's much more complicated, and we have to figure out a strategy on how to best treat the patient, whether the patient gets chemotherapy first versus breast surgery first. It's a complicated thing, and we all have to put our minds together and figure it out.
So in the population that are in their 20s and get this devastating news,
Mm-hmm.
and that still want to have children or have, a normal experience,
Right.
breastfeeding their child, that kind of a thing.
Yeah.
Can you still breastfeed after?
After reconstruction, no, because all
Right.
the breast tissue is removed.
Mm-hmm.
So no, so that's not a possibility. It's a very complicated thing when such a young patient comes into our office with a new diagnosis, because we have to consider not only the immediate result of the surgery, but also we have to think long term.
Mm-hmm.
They have so many years ahead of their life that we have to figure out a way to treat them where it doesn't affect them long term, where they're having to have surgery after surgery after surgery after surgery because of issues with the way that the reconstruction was done. So in those situations, I oftentimes guide the patient and say, look, I can put in implants. Maybe your friend has cosmetic implants and they look great, and maybe that's sort of affected the way you think about it, and you want implants at such a young age to do your reconstruction. But honestly, it's not. They may look fantastic for 5 years or 10 years, but when you're 50, 60 years old, they're not going to look good. Where you're going to have to have more surgery to fix the problem of having your implants in for that long a period. So it's better to do tissue reconstruction in that setting. But that's just looking at from a reconstructive standpoint. Now, let's say somebody comes in that's 20 years old and wants to have a family, wants to continue to have a family, and the chemotherapy that they're going to get is somehow going to affect their ability to have children in the future. Now you get into a completely different
harvesting
field.
eggs.
Exactly.
Right.
You have to have a fertility specialist to harvest eggs and things like that. So it's a big and
well, that begs the question: these young women that are out here getting these crazy breast implant surgeries really young, and what's that going to be like when they're 50 and 60? If they're getting them removed every 10 years, this is not healthy.
Right.
This cannot be healthy, folks. It just can't.
Right. I've seen patients that have had them in for 20 years and they look fantastic.
Really?
Yeah. So it doesn't necessarily mean, like I said, at 10 years, mark it on my calendar, I got to go change my implants. It doesn't happen that way.
Just
so
per patient.
Right, it's per patient. They may be happy with the volume at 50 years old or 60 years old. They can go down on the volume, make it a little smaller, not as obvious that they've had implant reconstruction or implant surgery, I should say.
Well, are they doing fat? You know how like they can do fat injections now? Are they doing more of that too? Or more of can they do
not
that?
necessarily for cosmetic purposes. That's still being done occasionally. We use what we call fat grafting. We use it all the time for reconstruction. That is one of our go-to techniques, and it's an adjunct technique. It's something that we don't primarily use that for the main reconstruction, but we use it very, very often as a way to deal with certain contour. There's a little dent here, a little dimple here. We use fat grafting to deal with that.
So we saw on your website, what is DIEP?
Okay, so that is a kind of tissue flap that we remove from the tummy, and that stands for deep inferior epigastric perforator flap.
That's
okay.
Yes.
So
I'll just say yes.
So in plastic surgery, and I'm sure every specialty has its own sort of language.
Acronyms.
Right, exactly.
Yeah.
So the way that flaps, pieces of tissue are named in plastic surgery, it's either from where they're removing it or the blood vessels that are providing blood flow to this tissue. So that particular flap, the DIEP, gets its name from the blood vessels, which is the deep inferior epigastric blood vessels that originate in the pelvis, and they come up through the anterior abdominal wall, and they start to branch off like trees. So those little tiny branches perforate the rectus muscle, which is the six-pack muscle. They perforate the rectus muscle. They perforate the fascia, which is the strength layer of the abdomen, and go and feed the fat and skin overlying that area. So those are the small blood vessels, those little tiny branches that are called perforators. Those are the ones that we have to find and dissect with a microscope. So that's why it gets that DIEP, the perforator. Those are the small blood vessels that we use.
I see.
So is there a way to do it without having to cut those blood vessels? Like, can you just pull them up?
Like you pull up your socks?
When breast reconstruction really started to become something that was done on a daily basis, there were no microscopes around to do this kind of surgery, or there was, but there were very few and far between. So they started doing something called a pedicled tram flap. So what pedicled means is that, kind of like what we talked about
with the back muscles,
right,
swinging it around.
swinging it on a pendulum. That is called a pedicle flap because it's pedicled on the blood vessels, as opposed to a free flap, which is the DIEP flap. Free means disconnection from the body. It's free in space at some point in time for a small, and then you put it back in. So that makes it a free flap. So a pedicle flap means that it stays connected to its blood vessels. You never disconnect it from the body. It stays connected. And the tram, so the pedicle tram, it's pedicled. That's where the blood vessels are coming from. Tram stands for transverse rectus abdominis myocutaneous flap. So it would take the rectus, the transverse rectus abdominis, and we would swing it on a pendulum from the abdomen over to the breast. So you don't have to use a microscope in that situation.
They used to do that from the arm when they're like way back, origins of reconstructive surgery, from the arm to the nose, and they would let it grow for and they'd have it growing there for like 3 months, and then they would, once the blood flow and everything was established to the that's amazing. If anything, like this 45 minutes, I've learned that there are so many options.
There are tons and tons.
There are so many more options.
Right. And it's, you know, as a reconstructive surgeon, my approach is not necessarily to be the encyclopedia. I'm not just necessarily a reference person. So going into my consultation, I don't say, okay, you have option A, these are the risks and benefits. You have option B, these are the risks and benefits. Option C, these are the risks and benefits. You choose. I think that's doing a little bit of a disservice to the patient. You certainly want to provide that, but you also want to guide them in some way.
So clinically, this would be more sound.
So you have to sit down with the patient and say, okay, right where you are right now, whether you're a 20-year-old or a 60-year-old woman, what are your goals? What are your goals in life? Do you just want something so your clothes fit okay? Or do you want something that you're super proud of and you look good in a bathing suit? Do you have a ton of stuff going on where you're driving back and forth all day, taking kids to school and practice and this, that, and the other? Or can you take some time off and actually, recover from this kind of surgery? So based on what is going on in the patient's life, what their goals are, I'll say, okay, based on what your goals are, this is the best way to get to your goal. Option A is the best way to get to your goal. And these are the risks for option A. The second best way to get to your goal is option B. These are the risks and benefits. And then they can choose after that. But instead of, if you present somebody with option A, B, and C and risks and benefits, and you choose without really getting an idea of where the patient is in their life, they're more confused when leaving the consult than they came in before the consult. So it makes the decision even harder. So my approach is find out where the patient is mentally, psychologically, emotionally. Do they have support at home? What do they want to do in 5 years? Do they just want something so they can look good because a granddaughter is getting married, or something completely different? Right. And then I'll tell them, okay, this is the best option for you.
Well, let's take a quick break. When we come back, I do want to talk about prevention. Certainly, what types of prevention are actually out there versus mammography, CT, and all that. We'll be right back.
Don't you listen to what the man said?
Do your loved ones say you're not listening? Do they tell you the TV's too loud? Or do you have ringing in your ears or feel dizzy without explanation? Call Associates of Audiology. They are the experts at diagnosing and treating hearing loss and balance disorders for all ages. Call 210-334-0245 or see them at associatesofaudiology.com for a better quality of life. Don't let your ears keep you from hearing.
We are back. You're listening to Ask the Experts of South Texas. I am Dr. Davis.
And I'm Dr. Bledsoe.
And with us is Dr. Ochoa with plastic surgery, PRMA. And you can go to PRMA-enhance.com. You can call 210-692-1181. So prevention, if not eating certain things that are carcinogenic, I don't know how well that pans out. I think, what did they say, like popcorn bags in the microwave, avoid that. I mean, like, you can micromanage your life so much, but isn't the greatest propensity to get breast cancer would be genetic?
There's certainly a genetic component. The fact of the matter is that right now we still don't know exactly. We still don't know. We've identified a few genes that are specifically linked with breast cancer, specifically the BRCA1 and 2 gene. But there's other genes that have also some effect on development of breast cancer, and there's probably a handful of them that we've also identified, but they don't get a lot of press, like the BRCA1 and 2 gene, which got a lot of press when Angelina Jolie had her breast surgery. So there's a lot of genetic components that we still don't know about. Still, the majority of patients who come in, it's a brand new cancer in their family. It's not, majority of the patients come in with no previous family history of breast cancer. So it's a new,
oh, that's scary.
It's a new mutation. It's new to them. The majority.
What are the typical ages on that? Do you know? 40.
Well, my population, because I don't see every single patient that has breast cancer, so my view is a little bit skewed, because I'm seeing the women who are either having a larger breast cancer that needs mastectomy, or have been identified with some genetic component. So it's a little bit skewed. I don't see the whole general population. So in my population, it's the average age is around 53 years old.
Still very young.
Yeah. Those are the women that are having breast reconstruction. 53-year-old woman is usually the mean age of my patients.
So people should probably, what do they say, 40 years old, you start getting your first?
Right, start getting mammograms usually around 40, and those recommendations are different between certain societies, like the Society of Breast Surgery has some recommendations, the American Society of Cancer has another one, and those necessarily do not coincide. So anywhere between 40 to 45 years old, you start getting mammograms. Definitely, if you have a family member that has had breast cancer, that age is younger.
It kicks it back, 8 years, they say, 8 to 10 years?
Something like that. So you can start getting mammograms earlier if you have a strong family history. Certainly, if you find something abnormal on exam, you're taking a shower, you feel something, let's have it looked at, whether it's with an ultrasound or a mammogram, and then figure out what needs to be done at that point.
So what is, I heard about this, there's a type of breast cancer where it's triple negative. What is this? It's very severe. Right.
So the triple negative is, that name it originates from triple negative in terms of the receptors that are present on the actual cancerous cell. So the normal breast tissue has estrogen receptors, progesterone receptors, and another kind of receptor called HER2, which stands, it's a long name, but basically it's a type of receptor that stimulates growth of those cells. The closer it is to being normal breast tissue, the more likely that those breast cancer cells have those receptors. So if you think about it from a teleologic standpoint, breast cancer is sort of a regression of the development of a normal cell. It loses some of the characteristics of a normal cell. One of the important characteristics of a normal cell is that it figures out, okay, I cannot divide anymore because there's other tissue that is there.
Right.
When a cell becomes cancerous, it loses that ability of perception in a way, where it says, you know what, I'm going to continue growing no matter what's next to me. I'm going to continue growing and growing and growing and growing. So cancer in and of itself, it's sort of a regression in the evolution of development of a cell. So as you regress farther and farther and farther, you start to lose receptors. They don't make those estrogen receptors anymore because it's a much more primitive type of cell. So the more receptors that you're missing, that tells me that the cell is probably more primitive, therefore more aggressive. So that's where it gets triple negative. So triple negative cancers tend to be much more aggressive.
Gotcha. So that's when a mastectomy.
Mastectomy is most of the time. We know that women who lack those receptors and are young have a higher incidence of having a cancer coming back in their lifetime, maybe affecting their overall lifespan. So if somebody comes in, let's say 45 years old, to my office with a triple negative cancer, I'm going to say, look, we can do whatever you want in terms of surgery, in terms of reconstruction, but you have to consider that based on the characteristics of your cancer, there may be a higher incidence of having cancer in the other breast if you choose to keep it.
Okay.
And that's something of a discussion that is best had with an oncologist,
right?
To see, okay, it's a very complicated thing. What are the chances of you developing another cancer in the other breast within your lifetime, based on the characteristics of the cancer that you have right now?
Well, if you can just reconstruct,
right?
I mean, that's why we have you, right, Dr. Ochoa?
Right.
Okay.
So, are there any advances to reconstruction for somebody younger that wants to breastfeed?
For reconstruction?
Or for just,
So reconstruction, you're assuming that you're removing the breast tissue, and then you're putting things back. So there's nothing right now that we have.
So maybe they had a bad experience, and it wasn't due to cancer, and they want to breastfeed still? Is that what you mean? Like they had implants and it was preventing the option of breastfeeding?
Or even a lumpectomy, or...
I see.
If they have, let's say that they're in still reproductive age and they have a lumpectomy and radiation, they can still breastfeed.
Even with radiation?
Even with radiation. Now, the chances of breastfeeding, even in the general population, are not 100%. There's a lot of women that have issues with breastfeeding, producing enough to completely sustain the child.
That's a very good point. That's a very good point. So even if they took the steps to be able to breastfeed, they may not be able to.
Right. So in situations like this, it's sort of a coin flip whether they'll be able to breastfeed with previous lumpectomy and radiation.
That's why there's Similac.
Yeah.
Go to the store, HEB.
So you have those conversations.
Right.
Yep.
Yeah. With our reproductive age women. Yeah.
And some people report like arm swelling.
Yes.
That's
a very, very tough issue. What is called lymphedema. Lymphedema.
Is it common?
It's fairly common, yes. I would say probably around 5%. So the incidence of lymphedema lymphedema. What is lymphedema? Lymphedema is swelling of the arm that is usually on the side of the mastectomy. So what causes lymphedema? What is lymph? Lymph is a thin fluid that our body makes that is part of the immune system. The lymph system is very small, little not blood vessels, but little tiny vessels that carry this fluid back to lymph nodes. As part of the normal staging of breast cancer, lymph nodes have to be biopsied to determine whether the cancer has spread to other parts of the body, which would guide radiation. It would guide certainly chemotherapy. So as part of the breast cancer surgery, the breast surgeon removes the cancer, whether it's a lumpectomy or through mastectomy, and he biopsies some of the lymph nodes in the axilla. So that technique is called sentinel lymph node biopsy. Only 1 or 2 lymph nodes are removed that primarily drain the breast. Using that technique, the incidence of lymphedema has decreased significantly because now they're only removing 1 to 2. There is multiple lymph nodes in the axilla, 20 maybe, even more so sometimes. So if you remove all of them, the lymph flow of the arm can be affected.
I see, and it swells up.
Now, let's say that somebody has multiple lymph nodes that are involved in the axilla, and they have to do that larger, what we call axillary lymph node dissection. Not lymph node biopsy, but a lymph node dissection where everything is removed. 20 lymph nodes can be removed. Now, let's say 5 of those lymph nodes were involved with cancer. Now you have to have radiation on top of that. So now you're adding lymph nodes removed, plus you're adding radiation, which significantly increases the scarring in the axilla. So now you're in a perfect storm. The incidence of lymphedema in those women is very high. very high. So they're going to have issues with arm swelling. They may need to use a compression garment, whether it's a tight glove or a sleeve. They may need repeated physical therapy to get the arm swelling down. Now, there's new techniques probably used over the last 5 years where we are doing what we call vascularized lymph node transfer. So now with the reconstruction of the breast, we're able to find lymph nodes, usually in the groin area, keep them attached to the tissue that we're harvesting, bring it up to the axilla, and repopulate that axilla with new lymph nodes that were in the groin area. And so there's a lot of newer techniques that are being developed. We're involved with research constantly to try to figure out what is the best way to do it. How are patients doing after these kinds of procedures? What are the outcomes? So we're involved in a lot of things.
We've also had people on the show that have done a lot of stem cell research and the cultivating the red blood cells. Are you guys doing that at all post-surgery, or
no?
Not yet?
No,
That's
a very sensitive issue that's a very sensitive issue with breast surgery, with breast reconstruction. So the big concern is that stem cells are sort of primitive cells in a way. They're able to develop and to differentiate into multiple cells. Stem cells have an ability to make a lot of growth factors.
Right.
One of those growth factors is called vascular endothelial growth factor, which stimulates growth of blood vessels into themselves. So you always run the risk of saying that, okay, if you somehow harvest stem cells from somewhere, whether it's bone marrow, there's stem cells that live between the fat cells. So these are called adipose-derived stem cells. If you inject it into the breast that has previously had cancer,
it's gonna,
and now you somehow because of the development or the production of new vascular endothelial growth factor, which is caused by the stem cells, are you somehow maybe stimulating growth of cancer? Becomes a very, very sensitive issue. Now, studies have been shown that that's not the case. That is not what's happening. However, somebody can always make the argument that, well, how do you know for sure?
Yeah.
You know?
So lots of clinical trials.
Lots of clinical trials, right.
And research.
Right.
Wow, we've covered a lot in an hour.
And I have many hours left.
I know. You've got to come back on the show because I think there is a real lack of information in this topic. It's a taboo topic. People don't want to talk about it, but it's a lot of our loved ones that are having a lot of different instances, not just breast cancers, but even reconstructive surgeries, and they don't talk about it because it's just something you don't discuss, but we need to. And just the way medicine is going is just miraculous right now. So you've got to come back on the show and then maybe open it up to callers to call in and ask questions too.
Sure, my pleasure.
Because you are a wealth of information. I have learned a lot. So please come back on the show.
Of course.
So Dr. Ochoa, and it's with I will get this, PRMA-enhance.com. Call him at 210-692-1181, and then come see us for your balance, your hearing. We'll help you out at Associates of Audiology. We'll see you back next weekend, and can you come back next month?
Absolutely. Just let me know when.
Sounds good. We'll see you then.
Great.